Okay, good morning, everybody. Once again, hope everybody is having a great week. And today, as you can see on the share screen here, we have a really nice lineup of presenters who I will introduce a little bit more in just a couple minutes after our usual morning updates. As usual, we will have CME for this presentation and talk more future stuff. Actually, I actually mentioned next week we have Dr. Deborah Kaysen, a professor, Department of Psychiatry and Behavioral Sciences here at Stanford, talking about the COVID-19 effects of mental health coworkers and strategies to cope. With that being said, we'll move right into a couple brief updates. Our first update, actually, Dr. Huja, would you like to go first?
Sure. Good morning, everyone. I'm just going to share my slides. I'll start with the numbers for today. We have 20 COVID inpatients in the hospital, 7 of whom are in the ICU. And I went into a little bit of a deeper dive per request on some of the data, which I'll show you this morning. We had a peak of the number of COVID patients in our hospital since March 1st, really since the history of COVID at Stanford. On Tuesday, yesterday, we hit 28 COVID patients. So we're down to 20 today, which is better, but we'll have to continue to watch the trend. Of the 200 Stanford patients, since March 1st, 38 of them, or 19%, have been in the ICU, and that percentage has been rather consistent. Looking at transfers from outside hospitals, we are committed to helping our community and just, titrating that with our resources. And there have been 6 transfers from outside hospitals from the sites that you see here. Breaking down the age demographics, I wanted to show you this slide because we have seen a slight shift towards the younger population, taking a little bit away from this age group and moving it here. The older age group has stayed approximately the same. And we have slightly more female patients that have been affected by COVID in the hospital than male. Looking at a breakdown of the ethnicity, we continue to have just over 50% of our patients are Hispanic. And then the remainder of the breakdown you can see here between the different race ethnicities. This is out of 190 patients because 10 of them didn't have complete data. And then finally, the final few slides, just looking at the trends within Stanford. This is both the wards and the ICU being in red, wards being in orange. So definitely an uptick and one of the highest peaks we've seen, as mentioned just earlier this week. And then down below, you can see the daily increase in numbers. Looking at our 7 Bay Area counties, and I'd like to focus more not on the PUIs, but on the actual confirmed cases. So hospitalized non-ICU patients are reflected in orange, and you can see that dramatic uptick. And then the ICU patients are here in red. So both of them are increased. But you'll notice, compared to here where the ICU percentage was a little bit higher than the total, it's a little lower here because the age demographic is also younger. And then finally, looking at the different counties broken down, and you can see Santa Clara County here in purple. And I just want to thank my data team, and I will turn this back over to you. Thanks, Sarah.
Thanks so much, Jan. That was excellent. Dr. Christy Wang also had a couple updates for us.
Hi, thank you for letting me make a few comments before Grand Rounds. And I look forward to today's discussion. I want to give you an update on the drive-through testing. Self-scheduling is now available for symptomatic patients. You don't need to call for a video visit first. If you have mild symptoms, you can self-schedule on My Health for an appointment at the Galvez or Emeryville sites, and we anticipate opening sites in Los Gatos and Pleasanton soon. This testing will be done through nasopharyngeal swabbing. If you have strong symptoms or want to speak to a provider about your symptoms, you can still call for a video visit. Our sites are, at our sites, we reserve space every day for symptomatic, pre-procedure, and high-risk patients. Asymptomatic swabbing will continue. These samples will be mid-turbinate, and at this time, we're scheduling asymptomatic patients 2 days out. Thanks.
Dr. Wang, thanks. That was actually one of the questions we had last week in preparation for this week, so I appreciate that update. It's great to hear that we don't necessarily need a doctor's order to go and get scheduled for COVID-19 tests in the future. So that was one of the questions. So moving on right into our presentation. As Dr. Harrington said right before we started here, we have this morning an all-star lineup of presenters. Really, many of the presenters you guys know. I won't go too long into sharing their background because they've been with us really this whole time since we began in March. We have Dr. Christina Kong, Medical Director, who's going to start off from Pathology and Clinical Laboratory. Dr. Ben Pinsky, Medical Director for the Clinical Virology Laboratory. Dr. Scott Boyd, Associate Professor, Pathology Endowed Faculty Scholar for Allergy Immunology, and Niaz Banaei, the Medical Director for Clinical Microbiology Laboratory. They really wanted to, and we wanted them to come join us to spend the hour really presenting the most recent updates. Of course, diagnostics is the probably most common topic that comes up, and really allow a lot of time for Q&A. Thanks for those of you who've sent the questions in advance. We'll try to get to all those questions that aren't answered already in the presentations, and please start asking your questions and we'll try to get to all of them. So Dr. Kong, I'll start with you first, and I believe you're going to be sharing your slides. Great,
yes.
Thank you.
Yeah, thank you. So I wanted to just start by showing the most recent test statistics. We've done over 100 and basically now over 110,000 PCR tests in over 85,000 individuals. The positive rate overall is about 3.5%. You can see we went down to a low level and it's now increasing. And Saurabh Gumbar, who's on our faculty in pathology, broke this down by age group. So the yellow and green are over the age of 50. And initially, that is where we saw the higher rates, but that stayed low. That's staying really low now. So the people over 65 are staying home, and we're not seeing as many positives. But as Nira was saying, the increase has been in the younger age groups, and that's been climbing up. If you just look at our Stanford data and get rid of the samples that are sent in from external facilities, our positive rate is about 2.7%. I also just wanted to comment on specimen collections. As Christy mentioned, we are now starting to have samples taken other than nasopharyngeal. So there's an option for mid-turbinate, also known as deep nasal, or anterior nary swab. So far we're doing these as self-collect observed. The different areas that are starting to collect these specimens are getting training. So if you're at a site where this is not an option, then you can reach out to me and I can put you in touch with the people who have developed the one-point lessons and the training for these collections. One thing to remember with the different specimen types is that as you move away from nasopharyngeal, there is some loss in sensitivity. A positive is still reliable, but if you have a negative result and you have a high suspicion for COVID, then it's a good idea to repeat it. If you have a positive result, you should not repeat the COVID test. A positive result is highly reliable. And one other comment I wanted to make is that we have a critical shortage of the rapid test kits. So we are going to be implementing an urgent COVID test, which is going to take about 5 hours as opposed to the hour 90 minutes for the rapid. So for inpatients, we're going to move away from the stat or rapid COVID and into an urgent workflow. We're down to critical supplies. If we continue at our current burn rate, we're going to run out of the cartridges within a couple of weeks. So we're going to be sending emails around about this change in workflow. There's also going to be a one-point lesson about how to order the urgent test. And I will pass it over to Ben. And as he's getting set up, one other comment is that as you see the surges across the country in positives, it means that we're actually running into the test reagent shortages and the disposables that we use for testing. And so we're seeing shortages of supplies again. And so that also has been impacting some of our turnaround time. We're starting to hear from other hospitals and labs that want to send their specimens to us again. Because Quest and LabCorp are running 7 to 10 day turnaround times, and we've been able to keep our turnaround times below 3 days.
My video off. Thank you, Christina.
Great.
I'm going to continue with the molecular testing, the PCR testing for SARS-CoV-2. There we go. So first, I just want to remind folks of the different assays that we're currently performing at Stanford. I'll try to hit a bunch of the questions that were submitted earlier before the grand round. So thank you everyone for submitting those questions. As you all know, we've been running a laboratory developed test that obtained emergency use authorization from the FDA. This is a reverse transcription PCR assay that targets the envelope gene of the virus and is based on the WHO test. As Christina mentioned, there is a lot of supply chain issues that are again occurring with the recent surge in the number of cases. So to mitigate some of this, we have multiple workflows for the Stanford EUA with multiple different extraction instruments and PCR instruments to help keep up with demand. So we have that assay that is being performed. We also have two instruments from Hologic, a Panther Fusion and Panther. We've been running the Panther Fusion now for several months. This is also RT-PCR. It targets the ORF1AB region of the genome. And in addition, more recently, I have a nice arrow there, we've brought on Hologic Panther. This is on a similar instrument, but it uses a different method of amplification, transcription-mediated amplification, also targets the same region of the genome. These are the assays that Christina was talking about that will allow us to get around 5 hours of turnaround time. The LDT assay is a little bit longer. That will take us between 6 and 8 hours from start to finish. And then the final assay that we have on board is the Expert Express. This is the STAT or rapid assay that's performed in the core lab. This targets the envelope and nucleocapsid genes. And as was mentioned, we have a critical shortage of these cartridges. So this is a rapid test, but we will have to adjust and to testing with slightly less rapid turnaround time. The one thing I want to emphasize here is that we have done extensive comparisons of these different tests, and they all perform extremely similarly. So the only times we've been getting discrepant results is when the sample has a very low viral load, which is expected. So in those cases, the detection is somewhat stochastic when it's near the lower limits of detection of these assays. But otherwise, we're getting greater than 98% positive percent and negative percent agreement. So very good agreement between all of these assays. So you can trust the results of these tests. So related to that, there were a large number of questions about sensitivity and specificity of our RT-PCR assays. So to get at the question of sensitivity, we did a large study with the University of Washington that was recently published. It's occurrence and timing of subsequent SARS-CoV-2 PCR positivity among initially negative patients. So we don't have, every patient that is tested negative is not retested again in a couple days to make sure that we didn't miss a positive. So calculating the actual sensitivity for COVID-19 is quite challenging. However, we can look at the discrepance of those individuals that did have repeat testing in our study that was within 7 days. So you can see the number of eligible patients was close to 12,000. At that point, we had 1,000 positive initial tests. When those were eliminated, most of these individuals did not have a clinical indication for retesting. So we had 288 individuals that were retested within 7 days. And if you look at the discordance, there were only 8 discordants out of those 288. So that's a 2.8% discrepancy. So this is actually quite good performance of these particular assays, and was very similar to what was seen at the University of Washington, which was 4.3%. And in general, these CT values were relatively late, meaning the viral load in these samples was relatively low for the ones that were discordant at Stanford. So hopefully that addresses some of the questions about test sensitivity. So we estimate that the sensitivity for these assays is quite high. We also know that the analytical sensitivity is also quite sensitive, around less than 10 copies per reaction. Okay, so the other side of that coin is the specificity of these tests, and we've recently addressed this by looking at the large number of asymptomatic healthcare workers that occupational health did such a great job of screening earlier in the year, in April and in early May. So about 12,660 tests were performed on asymptomatic healthcare workers. We removed the duplicates, leaving us with 12,430. And you can see actually the breakdown of where these specimens were collected here on the left. There were close to 14,000 individuals with a negative result, but there were 38 folks with a positive result. That's 0.3%, which we've talked about here before. So if we break down those 38 individuals with positive results, 11 actually had prior symptoms. Recent prior symptoms consistent with COVID-19. 5 individuals were pre-symptomatic, meaning they developed symptoms shortly after presentation for their swabbing. And then there were 22 asymptomatic individuals. And of these, 8 had serologic evidence of infection. 4 had both IgG and IgM at the time of presentation. 1 had IgM and subsequently developed IgG, and 3 had IgG only. So if you take this together, you look at the estimated specificity, which is extremely high, 99.9%. So we'd estimate of this, there's 14 false positives out of this entire set. So this again is excellent performance for these molecular diagnostic tests. So another topic that has gained a lot of interest of late is pooled testing or group testing. So this is the idea that we can combine individual specimens and then test them in a pool. And if negative, we can report that entire pool as negative. So this allows us to massively increase our testing capacity and also conserve reagents. So shown here, and Christina made this nice slide, is pools of 4. Pools of 4 to 5 are what is recommended by the FDA. And then you can see here, if there's 1 positive in the pool and the pool is positive, we would then deconvolute that pool and identify the individual specimen. So the downside of this, so the upside is increased capacity, reduced reagent use, and by increasing capacity, you can test groups more frequently. So the idea would be that you would test individuals, say, in congregate living, like dormitories, long-term care facilities, prisons, and so forth, on a very frequent basis, and identify outbreaks and identify individuals in the pre-symptomatic phase before it gets out of control. So we're interested in applying this, and we did a prospective pooled testing study. We went for pools of 8. We looked at 110 total pools, which is 880 samples. Almost 43% contained at least 1 positive sample. You can see the breakdown here of how many positive samples were in each pool. So some pools end up with more than 1. If you look at the results here, the positive percent agreement isn't that great. It's between 70 and 75%, depending on the method. And you can see we looked at all three of the methods we have in the clinical virology laboratory. However, if you look a little bit more closely, the pools that were missed, all the CT values are quite late. And so this is expected. They're greater than 34 cycles, so low viral loads with a median of 37 cycles. And you can see the interquartile range is quite, all these are quite late. So importantly, none of the missed samples were diagnostic. They were all individuals that were being monitored. A number of them were in several of the clinical trials for various therapeutics that are ongoing at our institution. The negative percent agreement was again excellent, close to 100%. If you look here, some agreement plots as well as bland Altman or mean difference plots, you can see that in pools of 8, there's a shift of the intercepts, so a bias in the assay that if it's pooled, the assay gives cycle thresholds that are approximately 3 cycles later, which is exactly what you would expect with an 8-fold dilution. So we think this is performing as it should. The sensitivity because of dilution is decreased, but that is balanced with the increase in capacity for testing. So one of the questions is whether these late CT values are particularly meaningful. So the last part that I'll talk about is development of a diagnostic for detection of replicating virus. So this is a minus strand assay, and we hope to use this as a surrogate marker for infectivity, though we don't have that data quite yet. So as you all know now, SARS-CoV-2 has a positive single-stranded RNA genome that's shown here. There's the genomic RNA. And then viral replication involves the production of genome length as well as subgenome length minus strand templates, so shown here in this blue. So the positive strand is made into negative strand to use as a template for more positive strand that gets packaged. And then additionally, the plus strand is made into minus strand subgenomic RNAs that are then made into messenger RNAs that can be translated into the structural proteins of the virus. So the idea is that we can detect these minus strand species as a marker of replicating virus in clinical specimens. So the idea is this: it's a two-step reverse transcription PCR. So to detect the minus strand, you just do the RT reaction with a single primer. That's the forward primer to detect the minus strand. And then in the second part of the reaction, you do the standard real-time PCR to detect that minus strand that has been reverse transcribed. And at the same time, you do parallel reaction with the plus strand, so the reverse primer. And so in 2 reactions, you can get the distribution of both the plus and the minus strands. In our regular assay, we just throw all the primers and probes together in a one-step RT-PCR. So the regular assay is detecting both plus and minus strands together. So this took a lot longer than anticipated to optimize. There's a major challenge with this that people have known about for some time looking at single-stranded RNA viruses. There's a lack of strand specificity. This can occur through self-priming, random priming, and false priming. And some of that is shown here in this figure. The way to address this is to run reactions with only, with no primer in the RT, and that controls for some of this. So we optimized with multiple genomic targets and settled on the E, which has worked the most reliably. N we thought would be more sensitive, but it turns out to have a large amount of background. We tried multiple reverse transcriptase enzymes and TAC enzymes, multiple concentrations and varied incubation times, and finally got something that worked. So for a laboratorian, this is as good as we can get it. The linearity and the precision of this assay is quite good, as you can see for both the minus strand and the plus strand. And then our lower limit of detection is less than a half a copy per microliter of eluate. So it ends up being around 5 copies per reaction. So this is very sensitive and on the level of sensitivity with our standard assay. And so we have started running clinical specimens through this assay to get a better idea of its performance characteristics. So we've run 58 clinical samples so far. And what you can see here in the table and in the graph here is that if the minus strand is detected, the CT values tend to be lower, as one would expect. So the median CT here is around 20 cycles for the detected, whereas the not detected, the median is in the early 30s. You can see there is a bit of overlap. We're able to detect minus strand in up to CT values of the late 20s, around 27, but we're in the process of evaluating additional samples, comparing this to viral culture with some collaborators, as well as looking at the time since onset of symptoms in addition to the CT values of the specimens. So that is what I have for the nucleic acid amplification tests. I just want to thank you all again for inviting me to speak and participate in this all these weeks. And then also just to make sure that we thank and acknowledge the amazingly hard work that all of our laboratory staff has been doing over the last 5+ months, especially in clinical virology. Again, with the surge, they are working incredibly hard to get these tests turned around for our patients here at Stanford. So I'm going to hand it over to Scott right now to talk about all this nice serologic work that he's been doing.
Thank you, Ben. That was really great. Appreciate all the info. And there's definitely questions popping up for you and Dr. Kong.
Okay, hi everyone. I'm very happy to have the chance to give you an update on what's been happening with the serology testing, and also just to show a lot of data that we've been generating. I think this should give an update in terms of what we've been learning about the human immune responses to this viral infection. So I wanted to start off just by acknowledging that this is an ongoing big collaborative effort spanning many departments, both within the School of Medicine and also colleagues in other parts of the university. Many of the contributions of individuals I've pointed out in some of our previous talks about the development of our serological assays at Stanford, but just to point out again the great help we've had from the Kim Lab, Taya Wang's group in terms of getting the initial testing up and running, our help from the virology lab colleagues and many others in pathology, and many others that you see mentioned here who are on the clinical side, including infectious disease colleagues like Taya, and basically many of the laboratory members, folks in transfusion medicine, and the internal medicine colleagues who have really been key to all of this. In addition to the support of our departments in the biobank, and we've also had help from a couple companies that have been really assisting us along the way. So just to refresh everyone's memory, when we talk about the antigens of the SARS-CoV-2 virus against which we are measuring antibody responses, a lot of it is focused on the spike, which is shown here schematically. You'll hear me talking about the S1 domain of the spike, which is essentially this first half. The receptor binding domain, or RBD, is this part here, which interacts with the host ACE2 protein as one of the major ways that the virus can begin to gain access to the cell it's trying to infect. And if you look at the schematic of the virus in general, there's also other major antigens. One of them is this nucleoprotein or nucleocapsid protein. Some of the serological tests that are out there target this antigen, and so I'll mention that. And you can see the RBD it pokes out of the top of the trimer of the spike of the virus, and it can be in different conformations, but it's generally inaccessible, and it seems like quite an immunogenic part of the whole virus. Okay, so as I described in previous presentations, we developed our own laboratory-developed ELISA test at Stanford that targets the antibodies binding to the RBD, or receptor binding domain of the spike, measuring IgG and IgM. In addition, we've developed this assay which detects whether a patient's antibodies can block the binding of ACE2, shown in green here, to the receptor binding domain. If there are no antibodies present, then you can detect the ACE2 binding very nicely, because it has a good affinity for interacting with the RBD. If a patient has minimal levels of antibodies blocking that interaction, it looks like this. Basically, there's no real change. But if a patient has high levels of antibodies targeting the RBD in a way that prevents the binding of ACE2, then you don't detect the ACE2 binding in the second step of this assay. So this is something that we're now validating in the clinical lab as potentially a way to give some additional interpretation of what a patient's antibody levels may represent in terms of protection. As I'll describe, we haven't yet had the clinical data correlations to really give a definitive answer about who's protected and how much, but those data should be coming along as time goes on. A lot of this work has been done by Katrina Rutkin. I also mentioned Oliver Wiertzen in the group who's been doing a lot of this work. It's been a very nice collaboration with Peter Kim and Abby Powell, and the biotech company Atom has helped us by synthesizing some of the proteins that we're using. So this is a big overview. So these are some of our most extensive data to date, analyzing the responses of inpatients. So both those who were admitted and didn't have to go to the ICU, and those who were in the ICU, and the responses to RBD in the different isotypes. So you'll notice here that I'm also talking about IgA, and that's because we've basically done repeat measurements for all these samples with the same ELISA platform, but just doing it in the room next to the clinical laboratory where the tests are running on the automated analyzers, just so that we can get some additional replication of the results. So what you'll see here are data from 40 inpatients, 15 of whom were admitted to the ICU. All were confirmed by PCR that they were infected with SARS-CoV-2. Here we're seeing about 400 time points measured for the individuals concerned. And what we can see now more clearly, that we've had more time since the outbreak of the pandemic, is that people's IgM responses go up, initially quite rapidly, but within about 2 months, so this is days since symptom onset, 60 days is here, the IgM levels have really begun to drop down close to baseline again, although we don't have as many samples at the very latest time points. IgA in the blood, interestingly, shows a similar time course. It's already dropping substantially by a month and a half after the start of a patient's symptoms. IgG shows an increase starting around the same time as the IgM&A, but it does seem to show a persistent higher level of detection. So it is suggesting that, if there is longer lasting immunity, it seems more likely to be coming from the IgG if it's the blood-borne antibodies that are going to be responsible for that. So there's been a lot of curiosity, I think, about, how do the different serological assays targeting different antigens perform? And so we did side-by-side comparisons with the same samples with other ELISAs using the different antigens. So this is a ELISA done with the S1 as the antigen instead of RBD. And so, if I flip back and forth between the RBD version and the S1 version, you can see that the results are very highly similar. They show a similar time course, a similar decrease in the IgM&A, and a similar prolonged higher levels in the IgG. The absolute OD value that you get on these assays, it depends on the antigen and the amount that we had to code in order to get the best mix of sensitivity specificity. So you can't compare them exactly on the axis, but each has its own dynamic range. So essentially the S1 and RBD results look very similar. What about the nucleocapsid? This is sort of interesting because everything else in the assays is highly similar, but it really seems like there's a kind of a muted response of IgM to the nucleocapsid antigen. Otherwise, the results look really similar to what we saw with the spike antigens. So the IgG coming up, staying high, the IgA up and then back down within about a month and a half. So this is, in this case, no one really knows the pathological or the protective significance of nucleocapsid specific antibodies. It's inside the virus normally, so you wouldn't think of it as the target for neutralizing antibodies, but it is a way that has been used to monitor whether people have evidence of exposure to the virus. And for example, the Abbott immunoassay that's in wide use, it has this as its antigenic target. Okay, and this work was, as I mentioned, Kathleen Rotkin and Oliver did most of the assays that we're showing here. So here's a key question. I was showing you data from inpatients in all this. Now, this next set of data relate to outpatients and those who are asymptomatic but were just detected by screening. So this is what the data look like for outpatients and asymptomatic individuals. And the key thing here is that for most of these subjects or participants, unlike the inpatients, we don't have as many time points. Most of these are just a single time measurement for each person. But nonetheless, I think the results are fairly convincing. Because we had asymptomatic individuals shown here, we don't have the x-axis being days since symptom onset because these people had no symptoms. So we're doing it as days since the first PCR positive test. And so what you can see is that the IgM looks relatively similar to what we saw with the inpatients, but in the outpatients and asymptomatic individuals, it seems as though there's an initial increase, but then a more rapid decrease than we saw in the inpatients. So that could suggest that these antibody levels are going to continue to decrease. We're of course continuing to analyze new samples as we get longer follow-up for more individuals. This is based on about 149 people, and I think it starts to look like a picture which, as I'll show you, is somewhat similar to the responses that have been noted for other coronaviruses like the community variety. Another topic of a lot of interest is what's the relationship between the amount of virus that you detect in someone's nasopharynx and the immune response that's raised, at least measured by antibodies. And so with collaboration of Pinsky and colleagues in virology, and also with the help of Saurabh Gombar in pathology, we've analyzed the relationship between the cycle threshold for the initial nasopharyngeal PCR for individuals and their subsequent antibody responses for the first test that was measured in these individuals. And so this is a mixture of inpatients and outpatients. There's a number of other variables we have to consider, but just in broad strokes, the patients who have the highest or the latest CT values, they do tend to be those who have the lowest antibody responses detected. That would sort of fit with, in general, the idea that maybe the amount of viral antigen could be a driver of the whole immune response. Of course, they're being measured in different sites. There's the important question of what's actually happening at the mucosal sites that we're getting into currently. But just to show these data, there does seem to be that relationship. Okay, so what about the blocking antibodies that block ACE2 interaction? What do they look like in these patient populations? So here are the results for inpatients. This is that ACE2 blocking assay. So here we're showing the amount of ACE2 that is able to bind RBD in the ELISA plate. So if it goes down, it means that the patient had blocking antibodies. And so what you see is that, if you look at that compared to the IgG response in the inpatients, the blocking activity is detected in around the same time course. And the majority of patients show a significant decrease in the actual ACE2 binding to the RBD in the assay in the presence of their antibodies. It does seem as though it persists and it stays down for quite a while in these individuals also. That would be consistent with the higher antibody levels and the sort of persistent time course that we saw with them. In the outpatients, here we're considering not asymptomatic individuals, but all of the outpatient symptomatic subjects. So the axis is now days since symptom onset. You can see the increase and then looks like the beginning of a decrease of the IgG levels measured. The amount of blocking activity that we detect in these samples is definitely not as high as in the inpatient samples. And many individuals don't seem to show much blocking at all. That could suggest that, at least by the measure of this assay, they'll have less ability to prevent the virus's receptor binding domain from binding to ACE2 protein on the host cells. of course, this is a surrogate assay. It's done with purified proteins. As I'll mention, the results from other assays, including the neutralization assays using cells in culture, they give a higher fraction of outpatients or mildly ill individuals that show some activity. But I would say that the jury is still out in terms of what assay is going to be the best predictor of real protection of people in the community or those getting exposed to the virus through their airways just by contact with others. There's some other data I've shown a little bit of in the past, but we can show other examples now. What happens to the virus as a person's antibody response increases? And so this is a plotting together of the IgG in blue, IgA in red, IgM in green in individuals as they're going through their hospital stay. And the x-axis is days of symptom onset. This black set of points is the virus in the blood, or at least RNA-emia of the virus as detected from blood samples. So you can see that just as the antibodies come up, the viral levels crash in the blood and they become undetectable. That also coincides with when this ACE2 blocking activity develops in the patient. So it's certainly, it's correlative, but it does suggest that this could be indicating clearance of the virus as the antibodies are produced in the patient, at least from the blood. Well, what's happening at the mucosal surfaces, we don't know yet. Here's another patient where you see basically the same sort of pattern. And this one I thought was a good example because given the dense sampling that was available, you can see that their IgG has started to wane somewhat as we get to later time points. And the blocking activity that's detected also shows it's sort of headed back up toward the baseline, but it's still substantial at that later time point. So yeah, I think overall, I think the picture is coming into a bit more focus in terms of what the antibody responses are to this virus. Some of it is reminiscent of what's been reported even in very old literature about the community coronaviruses. So I think in one of the previous Grand Rounds presentations, I mentioned these challenge studies that were done in the UK back in the 70s, 80s, and 90s. In this case, if you infect individuals who have volunteered and given informed consent by the standard of that time with the 229E community coronavirus, their observation was that those who had higher antibody levels, this is the IgG plot here, those who had higher antibody levels prior to the challenge tended to be those who remained uninfected. Those who had lower antibody levels prior to the challenge became infected at a higher frequency. Their antibody levels decrease. This is within a year after that exposure. What was noted, however, is that when re-challenged, very few patients, only one of the number that they tested, had any symptoms. So I think even if one doesn't have complete protection, which in this case, a bunch of people who had been initially infected were re-challenged, 5 who had remained previously uninfected, and 6 of those who had been infected in the previous challenge all became infected. So it was really only 3 people that were able to resist getting infected the second time. But nonetheless, it does seem encouraging that none of the people had symptoms except for that one individual. So as time goes on, I'm hoping that we'll see something similar begin to happen with the SARS-CoV-2 virus, but that's of course data that we'll have to collect as we go along. So just to summarize what I've shown, patients with mild or asymptomatic SARS-CoV-2 infection based on this set of samples, in total, I presented data based on 210 people and 625 samples total. The mild or asymptomatic infections seem to elicit lower and more short-lived antibody responses as measured from the blood, including IgG, compared to the more severely ill patients. This ACE2 RBD blocking assay is also weaker in the outpatients, and it seems to be, I would say, based on the literature reports, probably less sensitive than viral neutralization or pseudotype virus neutralization assays reported in preprints and some papers that have come out. But we're still waiting to find out what will be the best predictor of true protection of patients in the outside world. One thing that might be somewhat useful is that both our RBD ACE2 blocking assay, which I showed you, and also the neutralization data that have been reported correlate well with just the total IgG that's generated in an individual. This is a case where here's the RBD specific IgG on this axis. This is a neutralization titer. So it's not a perfect correlation, but it does suggest that if somebody has their total IgG measured, it will likely give some clue as to what the other assay results would have been. And as I mentioned, we're now going through a validation of the RBD ACE2 blocking assay in the Stanford Clinical Lab to potentially be able to give more information for patients and outpatients about their antibody status. Some other serology updates. Those of you ordering this testing may have noticed that there have been results coming from other kinds of assays. That's in part because during the initial wave of infections, the clinical lab had ordered a number of commercial kits in order to have capacity and sort of spread our bets out. So we're running both the Abbott anti-nucleocapsid IgG assay and the Euroimmune anti-S1 IgG assay. Dr. Runshi in the special chemistry lab has been heading the use of these commercial kits. And both of these assays seem to perform well, not perfectly. We find that we're comparing them to each other, and we're going to compare them to the laboratory developed test. And we do find some discordant results between them. So that's something we should be able to update you on in terms of, when does one give a positive result when the other gives a negative. We do see, cases where Abbott is positive and that Euroimmune is negative, and the other way around also. So I think it's, remains to be seen what will happen in those relatively rare examples where the results differ. Also, I should mention that the IgM assay that we're doing, which is the laboratory developed test, we've improved it based starting in around June. And we're now quite convinced that the specificity of this assay is greater than 99.5%. That was based on introducing a second step of specificity confirmation, which rules out a majority of what we think are false positives in the earlier version of the assay. And so in this case, we're doing a second assay test where we make sure that the patient's IgM doesn't bind to any of the other assay components. So we think that's made the assay very, reliable as well. The IgG assay all along has set a specificity of 99.8% in our testing of historical negative control samples. And compared to where we were in April, we've now tested many more thousands of samples and have, I think, an even better grip on how these things are performing. So again, just to acknowledge the many people that have contributed to this, and all of you for your attention and the tons of really helpful feedback that we've gotten from the wider Stanford medical community, asking about the tests and giving suggestions and things. It's much appreciated. An area that we're diving into now is studying the mucosal antibodies and salivary antibodies just to see if they may be helpful or have some use in the whole evaluation of individuals. So thanks very much for your attention. I'll stop so we can hand it over to Niaz.
Dr. Boyd, thanks so much. That was excellent. While Niaz is putting his slides up, can I ask you to answer, Scott, do you know if we have total numbers of positive tests that have been done at Stanford for the IgG, IgM?
I'll have to look up the latest numbers. I think it's.
Oh, I have it.
Oh, good.
So, yeah, so the total number, I decided not to show the slide, but the total number of serology tests done is 23,884. The overall IgG positive rate is 1.9%. We've seen a sharp decline in the ordering of serology tests, so the 1.9% IgG positive rate is likely not reflective of the community positive rate.
Thank you. That's great. Okay, Dr. Banaei.
Hey, good morning. Thank you for the opportunity to share with you our progress on developing an interferon gamma release assay for detecting cellular immune response to SARS-CoV-2. So as Scott described already, diagnostic assays could be used to detect a humoral response, to know someone has been infected and has antibodies, and also to potentially predict who is protected in the future. There is another arm to our immune responses, is a cellular immune response where T cells are developed and deployed to the site of infection, where they can either kill infected cells or they can produce cytokines such as interferon gamma to kill the intercellular pathogens. And just in the recent weeks, there has been several studies that have been posted preprint. And what these studies are indicating is that the T cell response is the more durable response and therefore more sensitive response if we want to know who has been infected. And also these studies are proposing that that's the response that will correlate with protection. This is an example of one of the better studies that have been done where they show while the antibody response is pretty sensitive in patients with a history of severe COVID, once you go to patients with moderate and contacts, household contacts, the antibody sensitivity drops. In contrast, the T-cell response remains pretty sensitive in moderate and also in contacts, and then even in the healthy blood donors, you pick up about twice more individuals that have a T-cell response to SARS-CoV-2. So it is possible to detect a T-cell response in the diagnostic clinical laboratory. These assays are referred to as interferon gamma release assays. There's two methods that are currently FDA cleared for different applications. One is a ELISA-based assay where you take whole blood and you stimulate T cells with peptides. Here's antigen presenting cell presenting peptides. The size of the peptide determines whether you stimulate CD4 T cells or CD8 T cells. This is an overnight incubation. You can see those T cells that have been sensitized. They recognize their cognate antigen and produce interferon gamma. So you can measure the interferon gamma with an ELISA and interpret the test as positive, negative, or indeterminate. The second method is laborious. It's called an ELISpot assay, where you take whole blood and you have to purify the mononuclear cells, and then you dispense them into wells where essentially this reaction happens. And instead of measuring interferon gamma, you're actually measuring individual T cell spots that were producing interferon gamma. Currently, FDA has both of these methods approved for diagnosis of latent tuberculosis infection. And we've been using the quantiferon method, which is the ELISA-based method, for the past 15 years. And we have actually conducted numerous studies to understand how we can make these tests better. And it puts us in a good position to leverage what we have learned to develop an IGRA for detecting T-cell response to SARS-CoV-2. So in the assay that I'm going to present to you, we are stimulating with CD4 and CD8 peptides. The CD4 peptides is one reaction that consists of about 500 peptides covering the entire virus proteome. For CD8 peptides, it's actually about 600 peptides distributed into two pools called pools A and B. The cases and controls that we are validating the assay with consist of cases which include a cohort of convalescent plasma donors and another cohort of patients that are participating in interferon lambda therapy trial at Stanford. And then the controls are healthy blood donors. So here's what we're finding. When we compare controls to cases, the interferon gamma response is actually stimulated minus unstimulated. As you can see here, the control response is pretty flat, whereas with the cases, we're seeing a range of responses on an ROC curve at a cutoff of 0.08. You can get the sensitivity of 91% and specificity of 93%. And here we can see the difference between the convalescent plasma donors in black and interferon lambda therapy patients in red at day 14 post PCR positivity. The convalescent plasma donors are months out from their mild COVID infection. I also should have mentioned that both of our case cohorts represent mild COVID infection. In fact, some of these interferon lambda therapy patients are even asymptomatic. And I think this is the cohort that really allows you to challenge this assay to see, is it more sensitive than the antibody response? And what we have learned is that the concordance between antibody response and the T-cell response is actually quite high. Both assays are detecting most of the patients, and there's few individuals that are discordant between the two assays, but otherwise very high concordance. Showing you the CD4 response here, because it is the CD4 response that's making up the majority of the response we are seeing. The CD8 response is weaker, and this is what has been reported in other studies as well. So when you look at this response, it's actually not a very strong response. is a borderline to weak response. And that's actually because what's happening is that if you look at day 14 versus day 28 post-PCR positivity in the interferon lambda trial individuals, the response is actually quickly declining. And although you're detecting it, it's a weak response because it is declining. And this is very similar to what Scott just presented with the antibody response in the outpatients. And you see a similar thing in the CD8 T-cell response. So lastly, some preliminary data that I want to share with you. This is ongoing, another collaboration where we are looking at household contacts of index cases shown in red. So black are the contacts, asymptomatic in the same household. And so we are able to detect the T-cell response in these contacts. And so far, the concordance between antibody response and T-cell response is 100%. And so we need to conduct this study and see whether T-cell response is able to detect more of these asymptomatic contacts. So to summarize what I described to you, we have interferon gamma release assay that we have developed that seems to work pretty accurately in identifying individuals that have been infected versus uninfected individuals. However, so far, what we are seeing is a high concordance between the T-cell response and the antibody response. So it remains to be seen what type of immune response correlates with the protection, and depending on if it turns out to be a T-cell response that correlates, then we have an assay that we can deploy and use for clinical purpose. I want to thank different individuals that have contributed to this work. Kenage Morgeson is a postdoctoral fellow in my lab, and he's put his research studies on hold and generated all the data that I provided today. I want to thank Ta and Suchi at Stanford Blood Center for sharing samples from convalescent plasma donors, our colleagues in Adult ID, Pras, Upi, and Jason for allowing us to tap into their interferon lambda therapy trial patients, and then pediatric ID, Bonnie Maldonado and Jonathan for allowing us to collaborate with them on the contact study, our collaborators at UCSD for sharing reagents, and also a few companies for donating reagents. And thank you again for the opportunity to share our findings with you.
Dr. Banaei, thank you so much. And again, I just want to first say thank you to all of our presenters today. Ben, you were talking about how thankful you are to your team. We all collectively are thankful to all of you guys for everything you're doing for us and helping us with diagnostics in every way. So thank you guys so much for today. We went through a lot of great stuff. Almost 9 o'clock. We're going to go over just a little bit to answer some questions. Thank you for all the questions you and all the panelists have been answering in the background. As always, we will send out all the questions in a follow-up email. And any questions we don't get to here, we'll send out to our presenters to try to answer before we send out that email to everybody. So we'll try to get all the questions answered. Dr. Kenji Taylor, who gave a great grand rounds recently on our community care of our community patients, especially minorities, he's asking about community testing with Stanford as a reference lab. Are there efforts? There's been some concerns with high volume testing and reporting. This is less of a technical question, but about reporting results. Is there, beyond testing, beyond faxes and the portal, is there a way to get the reports sent out to the basically providers and patients beyond healthcare worker calls? This might be a tough question for you guys to answer, but it might be something we can send feedback to. Any thoughts on the reporting of the results out into the community, the tests that are being done at Stanford?
Yeah, no, I think that that's always a challenge. I mean, we can optimize the testing part, but getting the specimens in and getting the results out are, equally important and difficult to streamline. So there are places where we have interfaces that make it easier to get the results back to the patients. For Stanford patients, I mean, it's through MyHealth, and so that's something that makes it easier to access. We are also, exploring ways of using barcoding to be able to, help get specimens in. And then the question becomes, can we build other platforms that other patients that are not Stanford patients can use to access their results. So those are things that we are continuing to look at, but they're not easy problems to solve. And we are also partnering, excuse me, with community health centers to try to provide testing.
Great, thanks, Dr. Kong. One question I want to pull up, thanks Dr. Huja for also answering. Dr. Marcia Stefanik asked, there's a question that's been going on, been asked a few times for the last few months. You guys have been in a very tough situation of under a lot of pressure, trying to figure out sensitivity and specificity of a test where there's no clear gold standard. One thing we've heard, and I've seen this happen where we've had patients who have a negative PCR, but we find out they have a positive BAL or find out later they had a positive serology. When you're interpreting the sensitivity and specificity of the nasopharyngeal PCR, does that incorporate the possibility that the virus just may not be there? The test may not be positive. It may be a perfect test, but maybe the virus load level is not in the nasopharynx. Is that anything you've learned along the ways that help us kind of interpret a negative or a positive PCR?
I mean, I think one thing that we've learned is that the specimen quality is one of the most important things, you know, for sensitivity. If you have a bad specimen, then you're going to get a negative result. And that is a statement that's on the CDC website, that the most important part, you know, for an accuracy of the test is collecting a good sample. And I think Ben was about to speak, and so I'll let him address more about the variability in the test results.
Yeah, just to briefly answer the last part of that question, we have seen a small number of cases where the virus was detectable in a lower respiratory tract sample, but not in the upper respiratory tract. So that is observed with most respiratory viruses. So fortunately, in most of those cases, the clinical teams had high suspicion and sent other specimen types for testing. So that's, I think, something to be concerned about, in particular for COVID, but also for other respiratory viruses. Another thing that can be used in those cases is we have seen IgM be helpful in some of those cases. And in addition, we can test for SARS-CoV-2 RNA in plasma. And so we've seen that also be helpful if a lower tract specimen can't be obtained.
Gotcha. Okay, thank you very much. If a pooled sample is negative, will it be run a second time?
So a pooled sample will be resulted as presumed negative, and it will not be rerun. If a pooled sample is positive, that pool will be broken up, and each of those samples will be rerun to identify who is the positive.
Okay, great. One of the questions that came in last week was asking about commercial labs, particularly the PCR testing. Do you guys have any knowledge of the sensitivity specificity of those labs, Quest, LabCorp, compared to what we use at Stanford?
Yeah, so Quest and LabCorp are running the Roche and Hologic platforms, you know, similar to what we run at Stanford. So the variability in testing that you hear often has to do with what specimen was collected, you know, whether it was healthcare worker collected nasopharyngeal versus mid-turbinate versus nares versus saliva, you know, testing. So it has to do with the specimen collection and then transport, you know, how long it takes to get there, you know, was it kept refrigerated and all of that. The platforms themselves at the commercial labs are, you know, the similar types of tests that we're running.
Gotcha. Perhaps one question, one or two more questions, and then we'll send the rest of the questions out to you to see what can be answered as well. Scott, Dr. Boyd, you talked a lot about the IgM, IgG. One of the themes of questions, I don't know if we have I don't think the answer to yet, is taking the interpretation of someone with a positive IgG, for example. We get a lot of questions. A lot of patients are asking our community physicians, can I get an IgG test? But there's the concern of what to do with the results. Is there anything that can be inferred at this point of someone has immunity or not? It sounds like we're still in the process of understanding that.
Yeah, I think the key clinical correlation under controlled conditions, or at least carefully observed individuals, those data are still to be reported convincingly. So I think we're gathering the data, and once the correlations are established in terms of which assays are the best predictors, what levels of antibody or neutralizing activity or blocking activity are actually the best correlates of protection, then we'll be able to answer those questions more directly. But it does seem to require, it requires the actual field test to really know what is the important correlate of protection. And this is something that people have wrestled with in many other infectious diseases too, like influenza, or it's always something that's hard to nail down in human beings, where you can't freely manipulate all the components of the system. But that's my current understanding.
Well, you guys have been with us since the very beginning, and I know you'll be sticking with us throughout the whole way and keeping us updated on as we get more research on this. I really want to thank you guys again for really the presentation today. Thanks for everybody joining us and for all the questions. We will again send you out the remaining questions and try to get anything else answered, and then send out to everybody as soon as possible. Thank you again to all the panelists. I hope everybody has a great week, and we'll see you soon.
Thank you.
Thank you.
Thank you.